Okay, so in the interest of time, I think we can get started as well. The webinar is going to be recorded, so not accessible afterwards. So first of all, thank you very much for everybody to join us today for this webinar for the launch of the DHIS2 Cancer Registry Toolkit. The agenda for today is so of course now the welcome introduction. We'll have a presentation from Les, Mary and Morten from the York in how this project we have embarked on this project in collaboration with them. There will be then a presentation from the ISP Center from the DHIS2 on the toolkit itself. We'll have a short session on the Q&A at the end of the call, and then closing remarks and the next steps. Just some housekeeping. So in case you have any questions throughout the presentation, you can write it down on the chat. If there are any questions that we are not able to answer due for time constraints, we will publish those questions with a relative answer in the DHIS2 community of practice. We will provide the link to the DHIS2 community of practice by the end of the webinar. As well, the presentation itself will be available through the community of practice of DHIS2. So without further ado, I will hand over to Les and Morten from York. Thank you.
Yeah, okay, thank you, Stefano. Just one moment. What, this one? Okay. Okay, can everyone see my screen? Yep. Okay, so hello to everyone. Good morning, good afternoon, depending where you are in the world. My name is Les Mary, and I'm joined by my colleague, Morten Ervik. We're both from the International Agency for Research on Cancer based in Lyon, France. And so just wanted to take a few moments at the onset of this webinar. We know it's focused mainly on the tool, appropriately so, but just wanted to situate a bit of the context and firstly to extend our thanks, especially to University of Oslo and the DHIS2 group, Stefano, Brian, and others there for the work they've done and really allowing this concept to go forward in support of cancer registries, but also our international partners who've been working with us, particularly Rwanda National Cancer Registry, our IARC regional hubs, both in sub-Saharan Africa through the African Cancer Registry Network and the Caribbean IARC hub, which Sarah is here on. But then very importantly, those who've provided funding, and it's come particularly through Vital Strategies by way of Bloomberg Philanthropies. So just here now, we just wanted to draw your attention to sort of the work we're doing in general and how it connects to the tool and more broadly to the importance of cancer registries. So I'll just try to advance the slide, which is not working. This one. Okay. So in case those who may not be familiar, what is IARC? Well, it stands for the International Agency for Research on Cancer. And in fact, we're the specialized agency of the World Health Organization. And as mentioned, based in Lyon, France. And within IARC, we have a number of what could be looked at as academic units or research areas. And one of those is the one that both Morten and I belong to, namely the Cancer Surveillance Branch. We look at a number of things, but my responsibility is this left quadrant termed Accelerating Cancer Registry Support and Development. And that's where this project comes in. And in particular, which I'll show in one moment, very briefly, under the larger umbrella of what we call the GICR, which is the Global Initiative for Cancer Registry Development. But just to draw out your attention as well to some of the work on global estimates, we have a website, Global Cancer Observatory, and the reason I draw that out is because everything you see there, Morten has very cleverly been able to embed within CanReg. So meaning all the analytic functions that are there, broadly speaking, are also available to users of CanReg, which we'll touch on in a moment. That does link exactly to this project. So why are we at the agency so concerned with cancer registries and in particular the special grouping called population-based cancer registries. And I provide for you here this slide, which has been a basis of our work for the 60 years of the agency's existence. This is, for those who are not familiar, Sir Richard Dahl, who was knighted for his work on drawing out the causality between smoking and lung cancer. But he placed a particular importance and saw the deep riches, if you will, of comparisons of populations through cancer registries. And so we've continued this work both with the formation or the ongoing publications every 5 years of this IARC report called Cancer Incidence in 5 Continents. And from that, of course, we not only provide descriptive epidemiology, it allows us to do that, but then also analytic epidemiology around that. So we're very grateful not only to Richard Dahl and others who started this work, but of course to the registries around the world. But this is why we have also taken on as a cause to really support registries in their work and what they're doing. And one aspect of this has been in the domain of equipping registries with tools. As you can imagine, most of the countries we're working with, or at least the priority ones, are often found to be in low and middle income countries. And this provides some unique challenges, not to mention struggles with equipping themselves with the right software. So Morten, seated beside me, my colleague, is the developer of CanReg 5, which is a tool provided to registries for the management of their data, data entry, data quality checks, and of course, data analysis. And some of the logistical issues and really the core needs of registries gave rise to this tool and was developed some years ago. And you can find some of the details on this slide in terms of it being free and open sourced and available on GitHub. Notable features include as well that it can be fully customizable in terms of additional fields beyond the international standards one and the inclusion of other languages, etc. And also I draw out, and I think Stefano will touch on this, the tool embeds the IARC edit checks. So these are a series of comparisons, both on one field level, but then also multiple field levels, ensuring that the data is indeed compatible with what would be expected. In other words, we don't have entries of a female with prostate cancer, etc. And these, we're really happy to say, have been part of the work with the DHIS tool for the cancer module. And then finally, as already mentioned, the work on the high-end analytic reporting tools. And I again note the GCO, the Global Cancer Observatory, for you to get a feel for this. And so that has also been an important aspect for us, is to make sure that there is a linkage between the DHIS tool and CanReg, so to enable that function. So where did this work come from, and how did it originate? It originated via a project we called the eInnovate, together with many partners you see on towards the bottom of the slide on the right hand that I'd already mentioned. And it was really with the goal to standardize data transfer for data collection, but then also data transfer between these two systems. It's been developed with the partners I mentioned, the Rwanda National Cancer Registry, and then piloted thereafter with the IARC Caribbean Hub in Jamaica. And so this really gave rise then to the discussion around a global tool, which we're very fortunate that the group in Oslo did assist with. And all of this work, I should mention again to underscore, has been supported by Bloomberg Philanthropies via Vital Strategies, which we're very grateful for. So just to end and maybe make an important underscore is this notion of data sources for PBCR. So the tool itself in DHIS2 is not to be seen as a replacement for the registry, but in fact as a complementary add-on to the functions of a cancer registry, which would allow for data to be more smoothly entered, managed, and analyzed in the due course. So I'll stop there. I think I jumped over one slide on the GICR, but very quickly to say this is a global program we're running at the agency involving about 150 countries, from which all this work really emanates from. And the goal of the GICR is to support cancer registries worldwide, and this is one aspect of by which we're doing that. So we'll end there. We've left our contact information and also the website for GICR if there are any questions. But really look forward to your involvement in growing this tool and, of course, using it. So we'll turn it over, or perhaps Sarah was going to say a few words, perhaps about her experience there in Jamaica before moving on to the main portion of this webinar with the demo. Thank you so much, Stefano and others, for the time to introduce some of these concepts.
Thanks so much, Les. And good morning, good afternoon, everybody that's on the call. And thank you so much for being here. I'm just going to say just a couple of comments just to reiterate thanks to the partners that have enabled this project to come to fruition. Of course, IARC, University of Oslo, and Vital Strategies for the funding support. CARFA, my name is Sarah. I work at the Caribbean Public Health Agency based in Trinidad and Tobago, and we support, we run the Caribbean Hub, the IARC GICR Caribbean Hub here in the region. And we began this work back in 2023, I believe it was, when we were connected through IARC with the Rwanda National Cancer Registry. I think Mark is on. And it's been a process since then. We've been able to explore the DHIS2 cancer module here at CARFA. And we've also worked with the Ministry of Health and Wellness in Jamaica. I see Gail and others from Jamaica on as well. And we've worked with them to customize the module that was developed by Rwanda. And it's been operational in Jamaica now since December 2024. So they have over a year experience entering and utilizing this module at the National Cancer Registry of Jamaica. And it's been very well received so far. If there are any specific questions, Gail is on and she can answer them at the end of the meeting. But it's been a system that has allowed for National Cancer Registry in a country that has decentralized data collection for cancer registration. So if that speaks to you, this is a system that can help. And I think very, very important to the utility of this system is its integration with CanReg 5. For those that have CanReg 5, it allows for almost a seamless transition from one data application to another. And if also it allows you to utilize very important data analytics that are built into CanReg 5. So there's certain utility for it. It's not always needed. CanReg 5 certainly has performed this function for many years and can continue to perform that function depending on the local context, but it certainly provides an alternative where it's needed. So with that, I'll hand over to Stefano, and he's going to give you a demo of the tool.
Great. Thank you very much, Sarah. Thank you very much, Les and Morten, first of all, for your availability and for the background that you provide about the project. So I will start my presentation. I'm just going to share my screen. Okay, if you can just confirm that you can see my screen, and then I can proceed. Okay, I guess you can all see my screen. So, so one of the challenge of getting reliable, high-quality cancer data into national health system is something that is not really new. And the tools to do it, like CanReg 5 in particular, have been around and trusted for many years. So what has been missing in many settings is the bridge between the specialist registry software and the broader national health information infrastructure that countries already run and maintain. And that's exactly the gap this toolkit sets out to close. The story behind it starts with the Innovator project that was well described by Les and Morten, an initiative that asked a simple question: can DHIS2 already deployed across so many national health systems serve as a CanReg 5 aligned platform for cancer case registration? And the answer, tested in Rwanda and then in the Caribbean, was yes. And with each implementation, the knowledge base grew. So before we drafted the global reference configuration, we went back to the community, to the registry, to the HIS2 implementers, and the registry managers, and we listened. What works, what breaks, what every registry needs, regardless of the context. And that experience is baked into every design decision that you will see today during the demo. So what are you looking at? It's not a prototype. It's a toolkit built on real implementation experience, grounded in the current 5 standards and designed to live inside infrastructure that countries already have. So the toolkit that you will see today didn't start as a global product. It started as a question asked in one country with one registry trying to solve a very concrete problem. Rwanda was the very first test. East Rwanda worked side by side with the Rwanda National Cancer Registry to build and run the system in a live operational environment, not a control test. Actual registry staff, actual case coming in from hospitals and laboratories, and actual data quality decision being made every day. And that experience shaped the earliest version of this configuration. From there, the work moved to the Caribbean. Jamaica came on board through the YARC Caribbean Hub, and other registry in the CARFA region followed. And with each new country context, the configuration had to flex. Different administrative geographies, different notification source type, a different way registry organized their workflow. Some of that flexibility was easy to accommodate. Some of it revealed hard limits in the design too. So alongside those deployments, we ran a structured consultation with the registry and HIS2 implementers across multiple regions. We asked them to walk us through how they actually work, where cases come from, how they manage duplicates, what happens when a record is incomplete. And 4 things came up consistently. So the first, the registry received cases from multiple sources, hospitals, pathology laboratories, death certificates, and others. And they need to consolidate them into a single verified record. Second, the data quality problem that almost always starts at the point of entry, not downstream. So checks need to be embedded right there in the form, not applied later in a batch. The third is the local adaptation that is unavoidable. But the current 5 aligned core has to remain intact. If you break that, you break the interoperability. And fourth, the biggest sustainability argument for using DHIS2 is that countries are already running it. Country module inside the structure create a so those 4 reasons are in design of everything you're about to see. So before we wrote a single line of metadata, we stopped and listened. One of the deliberate choices we made in developing this toolkit was to go back to the people who already been through the experience of implementing and running digital cancer registration system. Not to validate assumptions we already made, but to let their experience generally shape the design. So we spoke with many countries from many continents. We spoke with the Maldives, with Jamaica, with Uruguay, with Zimbabwe, with Kenya. There were many experiences that were brought on board. So the 3 things that came out of this conversation was first, clear picture of the pain points that came up consistently. Duplicate cases, incomplete tumor records, errors in linking notification sources to the right case. And those were not really country-specific problems. They show up everywhere. And any configuration that doesn't address them from the start will struggle. The second is a set of reusable design patterns, approaches to the duplication, multi-source notification, and quality control that have already been tested in real settings and it could be generalized. And third, perhaps more importantly, a shared understanding of what the configuration needs to adapt to local context and what is absolutely cannot change. Address code, source type, administrative geographies, those vary by country and must be customizable. But the current 5 aligned data model and the quality check logic must remain intact everywhere. That boundary is what makes the toolkit both flexible and trustworthy. And every design decision you will see today has a story behind it. So a registry that struggle with exactly that problem. So what does all those experience from many countries actually produce? Means what we have here in this loop. So the reference configuration rests on 4 principles, and they are worth being explicit about because they explain every design decision that you will see in the toolkit. So the first is the full alignment with the current 5. The toolkit is not an alternative to current 5. It is a feeder system. Every data element, every quality check, every record identifier has been mapped to current 5 standard So the data register in DHIS2 can transfer directly to Canary 5 without rekeying or manual transformation. Data alignment is the foundation that everything else is built on. The second is that the toolkit lives inside existing infrastructure. The country using DHIS2 already have servers, already have system administrators, already have a user management in place. A cancer module that runs inside that environment doesn't create a new system to maintain. It extends one that already exists. That is a sustainability argument as much as a technical one. The third principle is the most important one to get right in implementation. Localize. Don't modify. Some things must adapt. Address code, source type, administrative geographies are different in every country. But the core data elements, the core data model, the option set codes, and the quality check logic are fixed. Changing them breaks the Canary 5 alignment, and it breaks the checks. So the system design guide is very clear about where that line sits. And finally, it is available now. It's been just published today. It's free, it's open, it's documented, and ready to be deployed. So the reference metadata, the system design guide, the alignment with the DHIS2 Tracker implementation guide are all in the DHIS2 website. And that's the foundation. So let's now have a look of what actually the toolkit contains. So the DHIS2 Country Registry Toolkit is built around a single tracker program. No aggregate component, no parallel dashboard. Just a case-based system where every cancer patient is enrolled as a tracker entity and their data is captured event by event across 4 stages. So the first stage, that is not kind of for the ones that are used with DHIS2, is not really a program stage, but is the enrollment. This is where the patient record is created. So name, date of birth, sex, and geographic address. One important detail here is that at the moment of the enrollment, the system automatically generates a patient ID, following one of the conventions used in Canary 5, a 4-digit year followed by a 4-digit sequential. And data ID becomes the anchor for everything that follows. The second stage is tumor, and this is the heart of the system. Every clinical and epidemiological variable required for population-based cancer registry is captured there. Topography, morphology, behavior, basis of diagnosis, grade, incidence date, And critically, all the data quality checks are embedded in this stage. They run here at the point of registration, not as a batch process afterwards. This stage is repeatable because, unfortunately, a patient can have more than one tumor. The third stage is source. The cancer registry typically receives notification of a case from multiple sources: a hospital record, a pathology report, a death certificate. Each of those becomes a separate source event, and each is explicitly linked to the tumor it relates to via the tumor number that we will see later on. One tumor can have many sources. So you already see the hierarchical organization of the data model, in which we have a patient that can have a multiple tumor, and a specific tumor can have multiple sources. So it's very extremely important to be able to relate all of these different entities. And the fourth stage is a follow-up. So it's used to record the patient visit, the patient vital status over time, date last contact, whether the patient is alive, deceased, lost to follow-up. And this one is not linked to a specific tumor, but it sits at patient level. The underlying tracker entity type is person. So one enrolled person equals one cancer patient in the population-based registry. And this, as you can see in the system design guide, this entity can be shared in DHIS2 among several programs with some exceptions. So before we move into the demo, it's worth taking a moment to understand how the DHIS2 data model maps to what Canary 5 expects, because this alignment is what makes the whole system work. So the Canary 5 organizes cancer registry data into 3 record types: patient record, tumor record, and one or more sources records as well for the tumor. And the DHIS2 naturally mirrors these 3 tracker stages. The patient record maps to the enrollment stages, demographic, geography, and the auto-generated patient ID. The tumor record maps to the tumor stage. This is where all the clinical variables live. And each source record maps to the source stage event. explicitly linked back to its tumor via a shared identifier. Those identifiers deserve a brief mention. The tumor ID is a concatenate of the patient ID plus the value 01, the tumor number. The tumor ID source table follow the same logic for sources. Those aren't arbitrary. They're exactly the identifier that Clarify expects when it imports data. And getting them right is what allows the export application to reconstruct the full patient tumor source relationship on the other side. Then now on the right side of the slide is the coding flow. So the cases in DHIS2 are coded using the ICD-10 3.2 version. The topography, morphology, behavior, and grade. That is the operational standard for the cancer registration, and it's what registry staff enter at the point of registration. So for the moment, there is no ICD-10 in DHIS2, that's deliberate. So the ICD-10 conversion, epidemiological analysis, and international reporting all happens in Canreg 5. After the data has been extracted via the custom export application. So DHIS2 is the capture and the quality, the kind of a first quality control layer. Canreg 5 is for the analysis layer. The export app, there is a custom DHIS2 cancer registry export app is what bridges them, transforming the multi-stage DHIS2 structure into the flat record format that Canreg 5 expects without any rekeying. So that's the architecture. Now, in the demo, there is some pre-made video that I prepared just to avoid the last-minute surprise, as normally happen. And so what I'm going to show you here is kind of a complete case registration from the moment a registry staff member opens DHIS2 throughout to a verified Canreg ready record. And we will follow 3 steps. So the first one is we are searching before we enroll, this kind of the good practice. So before enrolling a new patient, we want to look if this patient has already been enrolled into the system, as we know the patient can move between different health facilities. You will see that when we enroll the patient, there is already an auto-generated patient ID. Of course, in DHIS2, you can set up this based on several patterns. Second, we will open the tumor and fill in the core clinic variables: topography, morphology, behavior, diagnosis, grade, incidence. And then third, as well, we'll add a source record, and we see how we relate each one of the source with a specific tumor. There are as well some program rules in DHIS2, some business rules that can prevent repetition of the same tumor number throughout the entire process. So I will and start here with a video. So what you are seeing here, I'm first looking for a patient, Perotti, via its attributes is not present, so I create one. Once I create the patient, you can see that the ID is already generated. Okay, so it's the year with a progressive number. This is based on the standard configurations where it is present in Canreg 5. Of course, this can be customized, but always need to go hand on hands with the actual Canreg 5 customization that is present in the country. Then I'm entering other key information: family name, given name, sex, and date of birth. For ones that are used to use DHIS2, that have seen other implementation of DHIS2, there are normally many more attributes that are collected at this stage. A very important and key message for this toolkit is that this toolkit can be used as a baseline for a cancer registry. That doesn't need to be modified, because modifying it can break some of the very complex checks that are behind the data quality. But of course, you can build up. So you can add new elements, you can add new attributes. But what is important is not to modify what is already there. So I'm recording now this patient, and now here I'm entering information for this tumor stage. There are some information that are mandatory information, the one with the red asterisks, and others. Here you can already see a first check. So I'm entering the incidence data, and I'm entering the age. This is a first data quality check in which I'm checking, okay, is the age based on the difference between the incidence date and the date of birth the correct one? If not, there is a warning message. A warning message in DHIS2 is a message that is still allow you to record the information. If you don't want someone to record the information, then it is an error message. But in this case, a warning. So, okay, you can provide them a fixed text message. So invalid age based on date of birth and incidence date, it must be 35. This is a calculated value based on the date of birth and the incidence date. So then the user, if one, can modify it. The address, as you have seen, there are some placeholders. Of course, for the address as well, this need to be based, the list of options need to be based on the different implementations. There can be several options, the way how you want to implement it, either through dependent drop-down list, in which first you select one administrative level, and then dependently you can select the others, or you can use organization unit value type. It really depends implementation by implementation. All of this information, of course, are present into the DHIS2 system design guide of this specific toolkit. But then let's go on the heart of the data entry. First of all, we need to select the tumor number. The tumor number, it doesn't mean to be a consecutive tumor number. So a person has a first tumor, then a second one 2 years later, a third one, how many years later. But it's just to provide a unique identifier to the tumor. This is very key because then it's what is used in the custom map to link the tumor with a specific source. Now here you are collecting the information. You will see that the options have both the name and as well the number to make the search easier. So you can search for the different option either by the name or by the code. So here we enter information for a case. And once we have entered all the information, you can see that, when I was still entering information, the run checks button was impossible to run because it was waiting for all the variables to be completed. All the variables present on the tumor and the patient section need to be present, except for the grade. The grade, you should enter a variable for the grade only if the behavior is valid. This is another check. So you will see the checks are implemented in several stages. One was for the age, another one for the grade here, and all the rest will be run separately. So once I have entered the information, I can save. There is no need to run the check. You can save it and enter other type of information as well. You think that the mandatory informations are very few. The mandatory information are only the tumor number and the date. All the rest of the information are not mandatory. So in case you don't have all the information collected since the beginning, then you can save it and complete it later on. Here you're seeing that to avoid data quality complications as well, what we can see, I'm sorry, because here I come back to tumor. So for the sources, what has been implemented is that here you have to select the tumor number to which the source is related to, is referred to. But in case there is the tumor number, the one that we selected was 1. Step 2 is say that this tumor is not present, was not recorded. So in this way, you can ensure that the UID that's going to generate it is linked to an existent tumor. And then all the rest of the information related with the source date and the source type. Of course, source type here, what we have implemented are placeholders, as the previous one that were shown. And of course, they need to be customized upon implementation based on the different needs. In case so you want to add more variables, you can do it. What is very important is that they are aligned with the actual configuration of current files that you have in countries in your Then, continuing with the presentation. So one of the features that of the toolkit that distinguishes it from a simple data entry form is that the set of data quality checks are built directly into the tracker. And let me explain how they work and what they are actually. So the checks are embedded in the tumor stage and run at the point of registration, not as a batch process applied to data after the fact. The idea is simple. If a registry staff members enter a combination of topography, morphology, and behavior that is clinical, implausible, the system tells them immediately, while they still have the record open and can investigate it or correct it. The checks are triggered by clicking on dedicated run checks button, the one you've seen during the demo. A deliberate action, not automatic. So this matters for two of the more complex checks. We will see later the morphology and topography consistency check and the multiple primary tester. This will require an extra steps that which involve a multi-step sequential logic and require their own separate trigger. An important point to be clear about is that the checks are not a gate. Data can be exported to Career 5 regardless of the check status. The purpose is to help registries maintain data consistency and epidemiological validity, not to block operation or prevent staff from progressing. And the checks produce two types of results. Rare flag means the combination is clinical and unusual, but not impossible. And it needs review and confirmation, but it could be a real case. An invalid result means the combination is logical impossible. It almost certainly reflects a data entry error and they should be corrected. So again, it doesn't technically prevent the export. All of this logic comes directly from the Career 5. So the original Java quality control checks have been translated condition by condition into the DHIS2 program rules. So let me walk through what the 10 checks actually are and what they detect. So on the left, the checks that produce are rare flags. So the largest group is the age combination checks, 3 checks that look at whether the patient age is possible given the morphology, the topography, or both combined together. And for example, certain morphology are extremely unusual in adults and others in children, then the system flags those. Then 2 coding consistency checks. One verifies the basis of diagnosis is consistent with the morphology recorded. And for instance, a microscopically confirmed morphology with a clinical only basis, of course, will be flagged. And the other checks whether the topography and behavior combination makes epidemiological sense. There is also a sex-specific rare checks, the sex versus morphology, flagging morphologies that are anatomically incompatible with the patient recorded sex. And finally, on the left, the topography morphology check. This one is a two-phase check. It first validates the morphology code, then tests the compatibility with the topography. And because of its sequential logic, it needs its own dedicated trigger button, not just. On the right, the 2 invalid checks. So grade, whether the grade entered is consistent with both the behavior code and the specific morphology rules, and the sex versus topography, which catches an anatomically impossible combination, like a male patient with a cervix uterus site. This is absolutely impossible. Then there is a special case, the multiple primary tester. This one doesn't, why special? Because this one doesn't reproduce a rare or invalid result. It produces 1 of 3 specific outcomes, either a duplicate primary, either a multiple primary, or unknown topography. It also requires its own dedicated trigger for the same reason as the topography morphology check. Then finally, there is one check that is implementing Career 5, but in DHIS2 doesn't really require program rules at all. It is the morphology validity, as in DHIS2 is enforced by the closed list, by the closed option set itself. So the user can only select valid ICVO 3.2 codes. So the check is built on into the data entry interface. So now coming back to the demo, and actually we run the checks, okay, in the case that we recorded earlier. So we walk through 4 things. For the first, I will show what happens if you try to run the check before all required fields are filled. There is a warning that fire and tell you exactly what's missing. The checks won't execute until that's resolved. This is one that I was showing before. We will show you again. Then I will deliberately enter a combination that trigger a rare flag. So for example, and then there is another one that is inconsistent as well, the topography versus the sex. And finally, I will show you the rare status section, because what I say before is that if there is a rare result, then there need to be a specific type of user that can validate this tumor. As you know, in DHIS2 it's possible as well to enforce this type of behavior. So the key message here is simple: check surface problems at the moment they happen, while the record is still open and while the staff member still has the context to investigate. That's fundamentally different from discovering data quality issue weeks later in a batch review. So coming back with another video. So here showing the rare status. So we have the same patient as before. Now entering information. So as before, reporting data, the incidence data, reporting data, incidence data, they've been kept separate. Okay, in case an implementation wants, they can rename the report data as the incidence data, but this will have an impact into the DHIS2 cost map for the exportation. So the decision was to be kept separate, as according to the implementation, the event date, the report data, can be used sometimes as a proxy for data quality, or can be there can be implementation in which they're using for any other purpose. So that's why we prefer to keep it separate. Then the age with the same type of first check that we have here, the check for the age, date of birth, and incidence date. You see that I didn't enter all the variables that are needed. That's why I cannot check the runs. I cannot run the checks. So here entering all the rest of the information as before, looking for the different options. As well, type of behavior, malignant, the basis for the diagnosis, histology of primary, still cannot select because the behavior is malignant. If I change the behavior, I can run the checks. Running the checks, you will see that you've seen that once I run the check, there is the separate run topography morphology check that appear. And they became mandatory because if I run the check, I want to run all of them. So this is where I want to enforce this type of behavior. In this case here, we see that all the information actually makes sense. And when I run the checks, you see that all the data entry is blocked. I cannot modify it. If I want to modify any value, I have to uncheck this. This is to prevent any data quality issue, because once I have checked, if I come here and I change value, then maybe there can be some mismatch in terms of outputs. So that's why we took those decisions. In case there is any rare, when it's selected, you can see in the warning message, there is explaining, okay, what is the rare? Is the rare basis. And once this is selected, you see that it appears another section that is the confirm the rare status. This section can be hidden to the users that doesn't have a specific type of role in which they can actually confirm the rare status or not. And this is for the rare. This is very important because following the current file logic, the rare status is something that you maybe don't want to include those records in your analysis, and identify them is important to have this type of information. Here is just an example of invalid type of information. So I'm a male and I'm entering a cancer, if I remember well, for uterus. So of course, this will provide an invalid type of output, but still, I can save this record. What is very important, in case you want to run any analytics into DHIS2, in your program indicator filter, you will have to exclude all the ones that will provide either a rare, either an invalid status, or a rare that has not been confirmed by a specific type of user. And all of this as well can be used, and here you can see how many rare and invalid. And then all of this as well can be used to be able to display in a either working list or online list, all the cases, all the tumors in which you have these alerts, either rare, either invalid, in case you want to do some review, or there are people that specific type of use that need to valid all the rare. You are able to produce this type of working list. So going back to the presentation, so another aspect, because the data entry that you have seen right now is, I mean, it's not that long. You only have, I would say, 3 different sections. You have the patient, you have the tumor, and you have the confirmation of rare. But in reality, there are many There are many sections that are hidden, that are used for the calculation of all these checks. So the visible ones, what you expect. The patient section captures the incidence date, age, and address. The tumor section is the primary data entry area. Then there is the check status, in which you run the checks and you receive the outcomes. And then there are status section, which, according to the user, are only visible to specific type of user, can either confirm or not the rare status of the tumor. But then there are 4 hidden sections that are never visible to register staff, but they are doing the essential work in the background. So the check section stores the results of each individual check as a data element. This is what the program rules write when checks run, and what the analytical filters read from. The morphology, topography, and multiple primary section, all the intermediate data elements needed by the 2 multi-step checks that are populated sequentially before the final results can be evaluated, in which is why those 2 checks need a separate trigger. On ones that knows the current 5 and the configuration is presented in GitHub, they know that all of those checks need to refer to a specific lookout tables. So that's why we have this multi-steps implemented in DHIS2. And the tumor ID section stores the computed tumor ID, the identifier that links tumor record to patients when the data is exported to Canary 5, and as well for the sources, the specific source for the specific tumor to the specific So I see that we still have some time. So maybe before let's go now for the cancer registry app. So the last piece of the toolkit is the custom export application. And this is where the DHIS2 data becomes the Canary 5 data. The problem itself is structural. So the DHIS2 stores cancer data across multiple program stages: enrollment, tumor, source, and follow-up. So the current file expects a flat record-based format where patient, tumor, and source information are consolidated into a single importable file. And this application bridges the gap. So it was originally built by Rwanda, specifically for the Rwanda Cancer Registry. And then the DHIS2 core team has since reworked it to make the field mapping fully configurable, meaning that it can now be reused by any country without watching up the story for patient, report source, and all records, and each producing a CSV file that current file can ingest directly. The mapping between DHIS2 UID and the current file variable names is stored in the DHIS2 data store under a specific folder. So you can manage it through the standard data store manager app, add a key, add the UID, save, reload. There is no need to any code changes or deployments into the app itself. So before we close, okay, if there is still some time, I want to show the data entry app, all the hidden section, just to show you. Maybe we can go through some of the most complicated checks. But before we close, a few important points for anyone planning to implement this toolkit in their context. So there are 2 things that must be adapted before the system is operational. The first is the address option set, of course. So the reference configuration ships with placeholder values, and this needs to be replaced with the actual administrative geography of the country. Current file uses a 2-level address code, typically combining region and district, and DHIS2 cascading dropdown needs to mirror that structure. The second is the source type. Again, placeholder that need to reflect the actual identification source the registry work with, hospital, pathology, laboratories, death registry, and so on. You can also add new data elements or attributes for local requirements, as long as you are not modifying the existing. What you must not touch is equally clear. The sex attributes use numeric codes that are referenced directly in multiple quality check program rules. If you substitute a differently coded option set, the sex-specific check will fail silently. No error message, just wrong results. So the same principle applies to all data elements involved in the checks. They must use a number value type with numeric codes. And the hidden tumor ID section must not be modified. It contains the identifier logic that the export app depends on to reconstruct the patient tumor source linkage in Carriage 5. On user groups, I mean, the toolkit normally ships with free. So admin managing metadata, but there is no access to the data. The access can view both, and data capture is the working group for the registry staff. But this, of course, can be modified according to different implementation. And finally, there are the three key resources that you have the link here on the slide. The first one is the system design guide. It is your primary reference for understanding every configuration decision in the toolkit. That elements, program rules, checks logic, identifiers, and so on. Then there is a demo instance, a public demo instance that is available for you to explore the system directly after this webinar. And then there is the metadata download, is where you can get the reference package itself and ready to install. All the three links are present here on the slide and will be shared later on into the chat. And as I told at the beginning, this has been published today, so it's extremely fresh. So to recap what we have covered, so the DHIS2 Cancer Registry Toolkit is a single integrated solution, a tracker program for case registration, and a custom export application to transfer data to CAREG 5. It is CAREG 5 aligned from the ground up, which means the data you capture in DHIS2 can move directly into CAREG 5 without rekeying or manual transformation. The quality checks are ported directly from CAREG 5 logic and run at the point of entry, not as a batch process after the fact. And the configuration was shaped by real implementation experience across multiple countries through East Rwanda, the CARFOR region, and the wider community consultation we described at the start. All the resources are linked on the previous slide. We'll be back on Monday, 31st March for the part 2, which covers everything you need to actually you need to know to deploy the toolkit. This means a step-by-step installation of the metadata package, an overview of the program rules, guidance on adapting the configuration for local requirements, and a full walkthrough of installing and configuring the export application, and guidance on where to go for technical support. And speaking of support, if you have questions after today, the best place is the community of practice of DHIS2 that has nearly 10 years of DHIS2 knowledge and over 1,000 members, so you're more than welcome to join the community of practice and more than 60,000 publications. The implementation and support categories are the right place for configuration questions. And there is a dedicated non-communicable disease category, and we will add as well one specific for the cancer registry. So before leaving the place for more, I just want to hear this is an actual configuration in which I stripped some of the program rules that were hidden the different section. I just want to show you kind of the information that you normally see are those one here, but you have many checks, many elements that the auto-populator are used for the calculation of the different checks. So all of those sections here, the checks, the multiple morphology topography check, the multiple primary tester, tumor ID, all of those are hidden sections, but that are key for the calculation of the different checks. So I will stop there, and I don't know if there is anything Morten, Les, or Sarah that you would like to add to complete from the presentation. Thank you.
Yeah, thank you very much, Stefano. I think you gave a very nice overview, and I hope that people had an opportunity to see all the functionality that you and your team have been able to build. I think it was very well explained.
Great, thank you very much. I can see many comments in the chat. I'm trying to go through it from the right now. For the ones we will not be able, okay, I can see now one, for example, from Amanda Bendor. Can you share how patient ID creating the system aligned with national patient IDs? So the way how you can create those patient ID in DHIS2, there are actual functionalities for auto generation of those UID that as well are checking for to avoid duplicates of same UID. And of course, it can be enforced. The partner that are used for the auto generation can be enforced based on the local implementation. So in case there is a national UID to be followed, can be enforced. What is important is to maintain the alignment, mapping between the DHIS2 and your current 5 that you are in touch with in case you have one.
Yeah, Stefano, there were two questions on registries we quickly touch on. One related to ICDO 10, which you mentioned, and I think Gladys, one of our IARC regional or centers of expertise, answered that it's ICDO 3 and maybe soon to be 4. That's the core. ICD 10 is used for reporting, which is the international standard for registries. The other talked about whether CanReg 5 is the only available kind of platform. No, it's not. As mentioned, we have put this forward as a free and open source software, and our first priority was to make the link with DHIS2. But of course, registries are free to use whichever, and then in that instance would need to have some sort of tool to port the DHIS2 capture of cases into their registry platform.
Yeah, exactly. I mean, examples of DHIS2 interoperability or ability to transfer data from a platform to another one here is just one of the examples, main example with the CanReg 5. But as you will know, DHIS2 now is used in more than 100 countries as either the health management information, the national health management information system, or more vertical for some specific programs. So one of the key capabilities of DHIS2 is something that the university is investing a lot recently is really to improve the extensibility and the interoperability capabilities of the DHIS2 with other platforms. So what was built for the current 5, of course, can be built for others. There are already some connectors that are present right there for some classical platforms like Tableau, Power BI, or any other platform, but as well for ones that are normally used for the data collection or either data analysis. So DHIS2 can be placed in either covering the whole data life cycle from collection to data collection, data entry, data collection, and analysis, or cover just some of them. For example, in this case here for current 5 is covering the first 2 steps, while the analysis is covered by CanReg 5 or any other. So it really depends on the different implementation. And I've seen as well some question, for example, if the DHIS2 configuration can be adapted and reused for other chronic disease. There is on the well, I forgot the terms, but yes, of course. I mean, DHIS2 is fully configurable. So as well, the configuration to be provided, the toolkit is in this case, is a reference configuration. So you can use it, you can modify. In this case, for the cancer registry, we say you can use it better, not to modify, because if not, you can break all the logic behind the rule. But of course, you can modify and add new variables, add new fields that are needed for your specific content, for your specific use cases. So in case you are doing screenings, I think cancer is something that is very logical. Of course, you can include all these aspects into the platform itself. Something that, for example, we had a lot of example with HIV prevention and HIV case surveillance, how the cases are linked together.
I have one question on national ID, if that can be aligned with the automatically generated ID, and it's linked to your comment on the fact that you can add fields to it, right? Because this automatically generated ID is just a reference within the CanReg or in the DHIS2 system for the patient ID, but you shouldn't use any national ID there. But you can, of course, add another field for national ID so people can collect that as well.
Yeah, exactly. So on the recent time, I'm really sorry because sometimes we need 1 hour and a half for webinars and etc. And I know that I took a little bit more of time, but I just want to make sure to transmit all of the messages. So for the questions that are not going to has not been answered that are present on the chat, we will answer them directly in the DHIS2 community of practice, so you can find the answer there. In case you have any other question, in case you are interested, you have any question for implementation, how to install, etc., we'll have another webinar on the 31st next week at I cannot remember the time right now, but I'm really sorry. the same time in the 31st of March. So you are warmly invited to participate. If not, please use the DHIS2 community of practice to be able to engage with us on this. So again, thank you very much for your participation and for all the questions. Thank you very much to Les, Morten, and Sarah for the presentation. And hopefully we will see again in 1 week time. Thank you very much.
Thank you, everyone. Thank
Thank
you.
you.
Thank you.
Thanks.
Bye-bye.
Thank you. Bye.